Dr. Anand Bangera. He is the professor and former head of KSEGDE Medical Academy, Mangaluru. He is the chairman of IDA Mangaluru chapter and former national vice president of IDA. Over to you, sir.
Good afternoon. We all know that pain is the worst suffering of mankind, and we, being the anesthesiologists, should have our role in managing every aspect of severe pain. Pain, may it be an acute pain or a chronic pain, we have the definite role. Management of acute pain, the worst suffering with the acute pain is when a patient suffers with a major trauma. And also, the other worst suffering is the labor pain, but I am not going to touch about labor pain because we had a lot of discussion, and we had discussion yesterday about labor pain by the pioneer of labor analgesia, that is Dr. Bhavani Shankar Kodali. Now, regarding management of acute pain in a trauma patients, there is a concept of on-arrival block. The concept here is, as soon as possible, if you can manage the pain in a patient who arrives in a casualty or a emergency room, it has got multiple advantages. It is a human principle which improves patient confidence in the system. That means as soon as the patient arrives, if you do something to relieve his pain, that means he gets definitely the most confidence with you. It avoids administration of major opioids for pain, which further affects the assessment of the patient, especially when there is a associated head injury. A tourniquet can be applied without causing much pain whenever you have we have given a block to relieve the pain. Detailed other clinical evaluation can be done much better way. Patient can be shifted to areas of radiography like X-rays or CT scan in a much better way, because whenever you shift the patient from the bed to the trolley to the radiography table, patient suffers the worst pain. This particular picture I put from the first publication of this concept of on-arrival block from the pioneer hospital of our country for trauma, that is from Ganga Hospital, Coimbatore. They presented a paper. You can imagine a patient with this type of penetrating injury, what is the amount of pain and the suffering he has, and if you can relieve his pain with some block techniques, that is nothing like this. This is the words, sentences which I have taken from the first publication by Dr. Balvenkat and team. Now, if there is a upper limb trauma, you can give any of these approaches for brachial plexus, either interscalene, supraclavicular, infraclavicular, or axillary, out of which the interscalene is much easier, and with the present day, where ultrasound is almost always available in the emergency room, especially for fast techniques, you can make use of the ultrasound and give these blocks to relieve the pain, either interscalene or supraclavicular technique. The technical aspects I am not going to in detail because it is very familiar now almost for all of us. For the lower limb, femoral block, even the landmark technique for femoral block is quite easier. It is not that difficult. Yes, with the ultrasound, it is much, much easier. A lower volume of 10 to 15 ml is more than enough. Here, it is not the complete anesthesia that you are supposed to achieve. It is mainly the pain relief, the instant pain relief that you are supposed to achieve. Similarly, if the injury is in the lower part of the leg or ankle, crush injury, ankle, foot and all, you can give a popliteal nerve block with the ultrasound with a similar picture like this. Now, chest injury patients, especially patients coming with the flail chest, you have to relieve the pain for multiple reasons. One is the pain relief, and the other one is to enhance the better breathing and thus to prevent the further complications of flail chest. Intercostal nerve block is one of the techniques, and there are many other techniques also. Though it is not very commonly practiced, intercostal nerve blocks are not that difficult, and especially when almost always in these patients will receive intercostal drainage, so the chances of pneumothorax is not a major problem for us. So intercostal blocks can be given at multiple techniques. Only thing is you have to take care of measures to prevent local anesthetic systemic toxicity, because that is the very vascular area. We are injecting local anesthetic agents at multiple levels. Ultrasound guided intercostal nerve blocks can be given. And yes, the technique which we are very familiar, that is the thoracic epidural. The analgesic dose of these drugs like bupivacaine or ropivacaine or levobupivacaine can be used to produce a good analgesia. Erector spinae block, nowadays all these facial blocks are becoming more and more popular. You can identify the different muscle planes, and if you can inject the drug between the transverse process and the erector spinae around 8 to 10, 20 to 30 ml of bolus dose followed by infusion, it will produce a good pain relief. Similarly, the paravertebral block, I am not going to explain the technique in detail. Now, for chronic pain, we have a definite role, because the physicians, the surgeons, they might have tried all their drugs, including many times even opioids have been tried. Then we have a definite role for nerve blocks. What sympathetic blocks that we can try? One is for upper limb, we have the stellate ganglion block, celiac plexus for upper abdominal pain, lumbar sympathetic plexus block for lower limb pains, superior hypogastric plexus block for perineal, pelvic, lower limb pains, and ganglion impart block for perineal and rectal pains. And also we have other blocks like interpleural block, paravertebral block, intercostal block, and suprascapular, and other the much discussed brachial plexus block. Yes, it is not that you try these techniques at once, just like that. When all other techniques or the intravenous drugs, opioids are tried, then only you are supposed to try these regional techniques, especially celiac plexus and stellate ganglion blocks, because it is not that safe blocks compared to any other blocks. Celiac plexus block, this is the little anatomy about the celiac plexus. The approach there are many approaches. The commonest approach is like this. You mark the costal margin, a triangle like this. Then you introduce your needle at the level of either T12 or L1, initially at around 6 to 8 centimeter from the midline. You go towards the transverse process. First you hit the transverse process, then you have to introduce the needle more in a longitudinal fashion. then go little deeper so that the needle tip should go anterior to the body of the vertebrae. Then you can identify the proper placement of the needle using a CIAM, using a injection of radio opaque dye, and then if you get a picture like this, then you can go ahead with either local anesthetics, sensor cane, bupivacaine or ropivacaine, or if you are very sure, you can use either absolute alcohol or 50% alcohol. Around 10 ml of 50% alcohol many a times is more than sufficient. Yes, you should always know about the complications, orthostatic hypotension, diarrhea, paraplegia, all these complications, and sometimes rare complications like this can also happen, so you have to be very, very careful. The hypogastric plexus, the concept here is almost same, the technique, everything is same. Only thing is here you need to give the drug slightly at a lower level, around L1 to L3 or L4 level. The identification, everything is same, and where it is useful is mainly for severe pain arising from bladder or urethra, uterus, vagina, vulva, perineum, or these perineal structures. The identification, as I told, is almost same. Now this intrapleural block, in addition to acute pain, can also be used for chronic pains like post-operative analgesia, or management of cancer pains, and also post-herpetic neuralgia. Nowadays you can identify the two layers of the pleura by using the ultrasound technique, and then you can either give a bolus dose or many a times using a catheter. Complications, you should be knowing it, so that you should prevent these complications. And now if you get a patient like this, severe pain in the digits, one side more than the other side, that is a patient having a very severe ischemic pain, the stellate ganglion block is very, very useful. Stellate ganglion block, we know about the anatomy. It is made up of the sympathetic ganglia of 6, 7, and T1. So there are landmark technique is at the level of the cricoid cartilage. You identify the Chisagne tubercle, or the much better technique is the ultrasound technique. The stellate ganglion is situated superficial to the longus coeli muscle. So you identify as shown here. You identify the stellate ganglion and inject a local anesthetic agent, around 68 ml of 0.25% bupivacaine, and if you are very confident, you can also use absolute alcohol. If you get a case scenario like this, a 72-year-old female with gangrene of the digits of the lower limb, you can use the lumbar sympathetic block. Even here, the principle and the technique is almost the same. Only thing is, it is given at the level of L5 and S1. It's useful for peripheral neuropathy, phantom limb pain, complex regional pain syndromes, and other things. As I explained, the technique is almost similar. First, you hit the go beyond the vertebrae, go to the anterolateral aspect of the vertebrae, and there if you inject the dye, you can identify, and then you can inject the local anesthetic drug. Now, epidural steroid injections, we are very familiar, and be specific. If the root pain is involving only one particular root, you can give transforaminal epidural steroids. You can similarly give ganglion impair block, where the approach should be through the sacral vertebrae, identify the ganglion, and then inject the drug. So in the face also, you can block different nerves, the different branches of the trigeminal nerve. The little easier techniques is to block the terminal branches of the maxillary nerve, that is the infraorbital nerve, either by the external approach or the intraoral approach, or you can also block the terminal branch of the mandibular nerve, that is the inferior alveolar nerve, and you can relieve this type of pains. So you can identify the root cause of the pain and treat these chronic pains in a much better way. Thank you very much.